Perfect.
Good morning from me here in San Diego. Want to welcome all of you. Have a special guest this morning, Dr. Maryam Motlagh. She is a practicing dentist in Portland, Oregon, and she's also the founder and CEO of Myoaligner. Her and I spoke just a few minutes before we got started, and she's been involved with full mouth rehab and cosmetic dentistry and TMJ treatment for years, actually about 20 years now, I would say. Good morning, doctor.
Good morning, Cheyenne. Thanks for having me today.
You're very welcome. So the typical general dentist, either one, wants to stay away from TMJ, and two, when they want to treat TMJ, they think that is with a night guard. Tell us why that's wrong, doctor.
You're absolutely right, Cheyenne. If you want to clear a room, you know, when you have a room full of dentists, if you want to clear the room quickly, just bring up TMJ because everybody runs away.
That's right.
Yeah. So, and, you know, I think part of it is because we did not get proper training at undergrad. You know, I was a top honor student here at Oregon Health Sciences University when I graduated in '98. But it's still, I felt like my knowledge of occlusion was very limited. And I was a patient myself, suffering from right jaw popping and clicking. And when I pursued my instructors, you know, they sent me to the oral surgery department, I remember, and they did an evaluation on me, and I ended up with a night guard, just a flat night guard for my upper jaw. That didn't help much, you know, and so I'm graduating here and realizing that I want to do a lot of, you know, big cases, complex cosmetic dentistry. So I ended up at a Spear Center back then in early 2000s. He was mainly here in Seattle, and a lot of seminars were hosted by him in Florida, Disney. So I used to go there and learned a lot about, you know, cosmetics, aesthetic dentistry. It was a great start to my career, to start with Frank Spear and his training. We got to do a lot of nice cases, but we mainly did equilibration on an articulator, and that was a problem for me, you know. And deep down, I knew that everyone's anatomy is different, everyone's muscle anatomy or jaw anatomy is different. So it's very hard to fully equilibrate a case on an articulator and then transfer it to the patient and expect it to be 100%. So in my opinion, we needed to use the patient as an articulator. So I ended up at LBI, you know, I know we've gone there. I was at LBI for about 4 years probably until I finished the curriculum. And I really liked what I learned about neuromuscular dentistry, physiologic dentistry, realizing that the occlusion was related to head and neck posture, C1, C2 alignment, and the whole body, the craniosacral alignment, really affects the occlusion, because the axis of closure for the occlusion is not from the disc, actually, it's from C1, C2. Sure. So Gouze theory. So I learned a lot at LBI, and I was able to do a lot of, for 15 years, I was able to do a lot of beautiful complex cases, which is the foundation of complex restorative dentistry. I mean, if a patient comes to you with severely worn down teeth and you see signs of pathology for 15 years, you cannot expect them not to break your veneers. If you put 24 veneers in their mouth, they're going to break it if you don't have the alignment correct. And I always use the car alignment analogy for my patients. I tell them, if your car alignment is not good, you're going to wear the tires much faster. So the solution is not to change the tires over and over again, but the solution is to correct the foundation. So what I really learned at LBI was the value of fixed or bonded orthotics. So before we started a case, we would relax the jaw muscles, you know, usually with tensing, which is very effective. So relaxing the jaw muscles, finding that ideal physiologic rest position for the mandible. And from there, we find the physiologic trajectory and put the patient in a physiologic bite. That doesn't mean that they're in physiologic rest, they're in physiologic bite. And these patients, ended up just being so stable. I have patients in full mouth restorations that were heavy grinders, and after 15 years, they haven't even chipped the corner of their restoration, and that's because the alignment is so good. So, I knew the value of fixed orthotics, and as I mentioned earlier to you, in my opinion, it was a big liability for me because not everybody needs full mouth reconstruction. And if it was a patient that had perfectly healthy teeth, I really wanted to kind of like transition them to ortho instead of doing reconstruction of them, or early patient in their early, mid 20s or 30s. In my opinion, they don't need full mouth reconstruction. But what I found out is that after a few months, that the patient was comfortable, I would give them an option to go to see an orthodontist or do partial or full mouth reconstruction, or just take this out, and that was really tough for the patient to give up this nice bite that they've had. But some of them couldn't even commit to further treatment. So I wanted to give them a solution. And I also wanted to give dentists a solution because, there's a lot of patients in our practices that suffer from this. According to National Headaches Foundation, there's more than 200 million Americans that suffer from headaches.
Yeah.
And at least in each practice, there's 25% of patients that complain of TMJ and grinding and clenching. And dentists usually just listen to them. They make them an eye guard, or they send them to an oral surgeon. And the dentist never just participates in their treatment. These patients are not getting any help. Even oral surgeons, the best oral surgeons that I have, they say, if you do jaw surgery, and the bite is not addressed, after 10 years, you're going to be back to step one, and that TMJ is going to break down. Don't you agree?
Right.
So, so what I ended up doing, I realized that, there's a great potential for dentists. If there's in an average practice that you have about 1,000 active patients, in a very small practice with 1,000 active patients, that means there's 250 patients that are expressing their concern to the general dentist, and they need some kind of a treatment, predictable treatment. And, an average treatment for Myoaligner and TMJ is about $4,000. If they go into oral surgery, yes, it's going to cost them tens of thousands of dollars and braces and things like that. But if they get started with a good orthotic, it's $4,000, and so 250 times 4,000, that's $1 million production that's sitting in a general dentist's office that could be production. Not only that, the dentist can really play a role in impacting public life, public health, and help these patients and make treatment more accessible to them. Usually when you refer and you say, I'm going to refer you to an oral surgeon, a lot of patients just continue with pain and discomfort. They don't want surgery. They've heard horrible, stories about jaw surgery, so they don't go. But that very same patient can be handled in a general dental office. If you really ask me, about more than 80% of patients show signs of TMD, temporomandibular disorders, but about 25% of them complain of the pain. So if a dentist, is trained to look for the signs, for scalloping, for abfractions, for a narrow airway, tori, things like that we are trained to look for, but we just need to see that they're connected to airway and TMJ. So
yeah, actually, Maryam, this is such a big discussion, right? I mean, it really gets involved with, and I've been involved, as you know, as well, with TMJ full mouth rehab treatments as well since about 2003, 2004. Fixed orthotics are very powerful when you're doing full mouth rehab. It's not a permanent treatment. It's a reversible treatment, depending on the amount of time that the patient wears it. And we're going to talk about this a little bit as well, as far as the Myoaligner being a removable appliance that gives the leverage for patients to have some longevity with it as far as wearing it long term.
mm-hmm.
But with that said, there's just such a discussion. There's so many female patients in their 40s, 50s that come into our practices with migraines, and there are so many male patients in their 50s and 60s that come in with severe wear, moderate to severe wear on their teeth. These are all things that we need to pay attention to. And look, when you're a general dentist, and I talk about this a lot, when you're treatment planning a case, when you understand the oral cavity as a system, then you're a doctor of the oral cavity. You're not a treating just teeth. And we use the term, being a tooth mechanic at some level. I mean, that's ultimately what you're doing. If you're just looking at teeth when you're doing your exams, if you're able to look at airway, if you're able to look at TMJ, if you're able to understand orthodontics, and realize that the majority of your cases is not an entrapment of the lower mandible, it's actually a deficient upper maxilla.
Exactly.
That's in the way. And so once you start understanding this entire concept of how everything moves around, then what it does is it allows you to expand your treatment planning. And this is one of the discussions we have a lot in Seven Figure Dental in my consulting, is that a lot of doctors don't have the potential to produce. The reason they don't have the potential to produce is they don't have that vision of looking at the oral cavity as a system. It's more like, tooth needs a root canal, tooth needs an extraction, tooth needs an implant. Even some of
Single
these
tooth
clear aligner.
dentistry. Yeah.
What's that?
Single
Even,
tooth dentistry, single tooth
yeah,
dentistry,
and
not
even
being a
quadrant
mouth doctor.
dentistry.
Yeah, yeah.
Yeah, even quadrant dentistry. The point is, you don't have to necessarily practice TMJ. You don't necessarily have to practice orthodontics, but and airway. But you'd be amazed at how much more advanced your treatment planning becomes. And quite frankly, I think, once you start dabbling into TMJ and airway and orthodontics, you're going to get really interested in how much more there is to the oral cavity than
Oh,
just.
yes. Yeah.
And I think
Knowledge
this
is
is where,
power.
yeah, and then I think this is where myoaligners and fixed orthotics come in handy. So 2017, myoaligners were founded,
Mhm.
right?
Yeah,
And
we we designed it, went through the patent process and all of that. So the next was like fine tuning the fit, as simple as they look, these are very difficult to make because we are basically crowning teeth that are not prepped. And as you know, most people that have occlusion issues, they have teeth that are going in different directions. They have bicuspid drop off, they have lingual inclination, they have anterior crowding, and all of that is very difficult to manage, when you're covering them with an appliance like this. So I think that's why majority of, even LVI dentists or ICMO dentists start with kind of like a really good anatomical orthotic, but made of acrylic, and I used to do that a lot too, but nobody can chew and function with them. So I think it doesn't help with bioremodeling. Plus the fact that if they're bite and chew on a full arch appliance, a lot of research in the implant world has shown that, because mandible flexes underneath, bones of, the face flex as we chew and function, and mandible does flex outward. So that puts even more pressure on the jaw and can cause temporalis tendonitis. So I started segmenting the design of a full arch, and noticed that it can come in really handy because it saves me time clinically. It saves me thousands of dollars. I used to start with a removable acrylic orthotic, and had a hard time selling that for $5,000 to patients because at the end of the day, they looked at it as a piece of plastic and they didn't realize how much K7 scans, and all of that I had done to incorporate into this orthotic. And ever since, and I'm giving them a tooth colored orthotic, even though it has all the anatomy that my acrylic orthotic has, all of a sudden patients see a lot more value in this orthotic. Do you understand where I'm coming from?
yeah,
They just look
and
at
the
it
other,
as restorations,
yeah, that and plus, compliance, right?
Oh, yes,
It's not
compliance.
removable in a sense, and it's not as bulky and it's not as cumbersome.
Exactly.
So those all play in favor of, easier case conversions. But, one of the things, do you actually have a sample? You want to show what it looks like, if you don't mind?
Yeah, so this is, the main sample that we send to most of our doctors. Is the quality good or is it kind of blurry?
Yeah, it's fine. I
Okay,
think we can
I
see
can
that. Yeah.
make it a little bit better if we do I don't know if a manual zoom would work here. So we designed two types. This is kind of like doctors that are interested in fixed orthotic. And, originally for a fixed orthotic, you need to do a full arch wax up. Most doctors pay about what? About $30, $35 per tooth for a wax up. And then you make a stent out of that. And then you fill up we fill up that stent with Luxatem or something. And in the patient's mouth, you just transfer it to the mouth. Even as a scaled practitioners, there was times that my stent didn't go in perfectly straight. It was canted. And then if the orthotic was really tall, it was really hard for me to clean up the linguals of 18, 19, 30, and 31. So on average, it took me about 2 hours to deliver a fixed orthotic. 2 hours of a productive doctor's time can be anywhere from $2,000 to $4,000, that I could have been producing other things. So this is the design of the fixed orthotic that goes only to the height of contour. So we leave the embrasures open. And you can this segment can be quickly cemented on with a temporary cement, or you can spot etch and bond it to the tip of the cusps. But you can see that can just go right on the teeth. Embrasures are open so patients can water pick there. And if an orthodontist wants to upright these teeth, they can just with a T3, you can easily remove it, section the bicuspids, put the molars back on, and start uprighting your bicuspids, expand your palate. So for phase 2, it makes it easier for orthodontists to work with it rather than cutting and sectioning a fixed orthotic that goes in the embrasures. So that's our fixed orthotic, design. This is the design that's removable for the patient, so you don't have to even use temporary cement on this. We get enough retention that this will go on all the way down. At night, we made mandatory for patients to glue them in, and all they need to use is some white denture glue. And that's enough to cause quite a bit of retention when it fills in the gap, and so they can remove that in the morning, brush underneath it, and then put it back on. So I have eliminated all acrylic orthotics in my practice because on average, it cost me about $350 for the acrylic orthotic. And then when I did a fixed orthotic, waxing up a full arch with $30, $35 per tooth, it was another $400, $500. So it cost me about $900 in lab work. And 2 hours of my time to deliver that fixed orthotic. So usually when you deliver a removable orthotic like a acrylic, you bring the patient back on, adjust it and everything. Now let's say that patient wants to go to phase 2. Then you have to transfer that into a fixed orthotic, pay extra lab cost, fine tune that orthotic again. So if you add it up, if you add up the doctor's time, you're actually wasting about $6,000 per patient if you go to 2 orthotics. So I eliminate the acrylic orthotic. I always start my patients on a removable like this. It's 3 segments. So if you have quite a bit of drop off on the bicuspid, it's going to be only one in the back. But if you don't have much of a drop off, we can give you anterior clearance. So that way you have your anterior clearance. Patient can chew and function with this for about 3 months. That's what I give for bioremodeling. So I see the patient on average of 4 hours during that the 3 months. For the follow-ups, when they come in, they get TENS for half an hour. I don't even see them. The assistant hooks them up to TENS. And then I go in and just adjust the orthotic if needed for half an hour. So total time for the Myoaligner is about 4 hours. And if you sell it for $4,000, that's $1,000 per hour that you're producing. Ends up being more productive than Invisalign for a lot of dentists.
Well, let me, yeah, and let me explain a couple of things here as well.
Yeah.
We with Love Bites, we're going to start teaching these types of treatments for your practices. Look, it sounds complicated, but really it's not.
No, it's
It's pretty
not.
straightforward.
Yeah.
Once you do a few, obviously you got to do a few, first year or two, like doctor's saying, it might take you a couple hours with a stent and Luxatemp, but once you get going at this, and right now with the stent, it doesn't take me much time at all. And like she said, you also have the flexibility to have the removable, which gives you compliance at 100%, which are big factors. But with our Love Bites program, we're going to start teaching these types of things where you're learning more about TMJ and more about how you can treat these types of cases and kind of expand your mind as far as not just being a general dentist. And Maryam, with Myoaligners, how can they learn more about Myoaligners?
So if you go to myoaligner.com, we follow Invisalign models. So we have a patient site and a doctor's site, and they can learn a little bit about it. And when doctors become members of Myoaligner, and we have waived the membership fee for the doctors at this point, because we really want them to learn to treat TMJ. So if they go and sign up, then they will show up on our locator, and also they get access to the backend, to the support page that we have put together. I shared that support page with you a couple of weeks ago.
Yes.
So they can learn how to take good impressions, so where they want to put the bite, where they want to give us that intraocclusal space really depends on their philosophy. So even if you're not a neuromuscular dentist, you practice CR and you want to open the bite, that's fine. You just give us that intraocclusal gap, and then we'll fill it in with Myoaligner for you. Patients, you can test drive that bite before you go to phase 2. Correct me if I'm wrong, but I understand majority of prosthodontists fine-tune the bite in the temporary stage. They first prep, they start with a acrylic orthotic, and then they prep and fine-tune while the patient is in the temporary stage, and then they take their final impression. With this technique, you can just do the overlays very easily before you prep, and fine-tune the bite before the patient is committed to grinding.
Yeah, and one of the things, and this is obviously patient compliance is important, but patient acceptance as far as what type of patient you have in the chair. If they're asymptomatic or if they're symptomatic with their symptoms, that's important to understand as far as how long you need to keep the patient in. There are a few things, there's obviously some details there that we need to pay attention to, but Myoaligners and Dr. Motlagh are gracious enough, they're sponsoring one of the sponsors for our online virtual summit, September 18th. So you're going to learn more about Myoaligners. She's going to be speaking on Myoaligners more in depth as far as how you can get started with Myoaligners in your practices and start the TMJ journey. So we're excited about that, Doc, as far as helping us with the sponsorship. And then obviously we want to educate our community, getting more involved. As she mentioned, it's a great added service to your bottom line. And I've done this. We've probably done hundreds of these TMJ type treatments now, and we've had great success. So it's a very predictable procedure. The science is supporting this treatment. With that said, we look forward to seeing Dr. Motlagh in the future. Thanks, doctor, for your time today.
You can call me M. M is fine.
Dr. M?
Yeah.
Dr. M it is.
Yeah.
I'm Dr. Shaheen Safarian. I'm the founder of Seven Figure Dental and Love Bites. And doctor, thank you.
You're welcome. It's been great to get to know you, and we share the same philosophy and goals, and I'm hoping that we can help a lot of general dentists and their patients long term.
Thank you, Doc. Have a great day.
Bye-bye.